Welcome to the fascinating world of pediatric regional anesthesia. Maxillary nerve block imbues profound analgesia for cleft palates and lip surgeries in infants and children. Furthermore, this can be used for many other indications as well. Here is our take on suprazygomatic maxillary nerve block with ultrasound guidance. This nerve supplies the midface, hard and soft palate, upper jaw, and dental arch and upper lip. Here are certain indications and contraindications for this block. Well, let's make anatomy clear as crystal.
This is pterygopalatine fossa. Anterior boundary is posterior wall of maxilla and posterior boundary is infratemporal surface of greater wing of sphenoid. Maxillary nerve enters from foramen rotundum and it comes out into pterygopalatine fossa and it gives most of its branches into pterygopalatine fossa and then descend down on the posterior wall of maxilla. Maxillary artery is derived from the external carotid artery behind mandibular condyle and it runs between two heads of lateral pterygoid muscles and enters into pterygopalatine fossa as a terminal branch and it gives further branches into pterygopalatine fossa.
A red arrow shall soon indicate the exact location. Watch out. The insertion point is shown here. The lateral rim of the orbit and the zygomatic arch is being drawn. The fingers are pointing out the trajectory of the ultrasound beam. And here is the probe placement to achieve that. This is another simple way of palpating the needle insertion point as labeled. Watch out the needle being inserted and its trajectory underneath the zygomatic arch. Note the probe position. Once the needle tip is inside the fossa, 0.2 ml per kilogram of 0.25% ropivacaine or bupivacaine is injected after ensuring a negative aspiration and is injected in aliquots. Here's the ultrasound scan. Note the greater wing of sphenoid and maxilla casting their acoustic shadows. And the pterygopalatine fossa, our destination, and the maxillary artery. The needle entry here is out of plane. And also, the hydrodissection caused by the local anesthetic, which is anechoic, is distinctly seen. Since the needle trajectory is out of plane, watch for the effect of the needle movement in the pterygopalatine fossa rather than a clear shaft entering inside. The LA is injected once in the fossa and the hydrodissection is watched for. What we have found in the postoperative period is a definite increase in the quantum of feed, which perhaps is a direct extension of the analgesia provided. Thank you.